Hi, everyone. Thanks for coming. We're very excited to be here. My name is Gillian, and I am a second-year master's in public health science student at KI, studying epidemiology. And I'm originally from the US. My background is in psychology academically, and I've also worked in the nonprofit sector for a few years. So yeah, that's about it for me.
Hi, everyone. My name is Eileen. I am also from the Master's Public Health program, but I'm in the Health Promotion and Prevention track. And I am from Tanzania, and my background is in health sciences and sustainable development.
Okay, good evening, everyone. My name is Simone. I'm also studying the Public Health Sciences program and in the Health Promotion and Prevention track. And I am from South Africa with a background in psychology and human anatomy and physiology. So welcome to this seminar on decolonizing global health. Thank you for joining us and showing an interest in this very important topic. We're very grateful for this opportunity and hope that this will be a space where you can learn and engage in what this whole decolonization business is all about. So the decolonization movement started at the University of Cape Town in South Africa, and I was privileged to have been attending this university at the time. As a former colony, there are many artifacts of colonialism that still exist in South Africa today, especially in educational institutions. In 2015, students at the University of Cape Town and other universities demanded that the colonial history of these institutions was acknowledged and addressed. So this involved renaming buildings, removing statues and other material changes, but also a fundamental change to the syllabi and research practices. And while this decolonization process applied to everything from literature to psychology, it is of course deeply relevant to global health, which we will get into in this talk. So this movement spread, and there are currently various groups around the world advocating for decolonizing global health. However, most of these groups are associated with public health institutions in the global north. And while the aim is to advocate for ways to overcome the colonial legacy of the global north, it can also be argued that the movement itself needs to be decolonized and driven more by the global south. So this brings us to our group, which is the Karolinska chapter of Decolonizing Global Health, Sweden. So this is a student-led registered nonprofit, and we were established recently in 2019. We are also in partnership with Karolinska Institutet. And in our short history, we have already hosted 2 conferences in 2020 and 2021, as well as created a policy document outlining the changes that Karolinska Institutet can strive for in an effort to support decolonial teaching and research practices. So you can follow us on social media like Facebook and Twitter to keep up to date with the movement and get yourself involved. So now let's take a look at the history of global health and the so-called legacy of colonialism. Coloniality refers to power relations that persistently oppress and benefit particular groups. So first, let's look at the 2 predominant types of colonialism. Settler colonialism occurs when a settler society invades and attempts to replace the original indigenous population with a new settler society. So examples include the United States, Canada, Australia, and South Africa. Extractive colonialism, also known as exploitative colonialism, happens when colonizers take control of natural resources and trade the export of goods. So this includes the slave trade. And examples of this are the Democratic Republic of the Congo and many other countries in Africa. The wealth of the global north was built on slavery, colonialism, and exploitation of the global south. Today, there are still over 60 low and middle income countries that are paying debts to high income countries. And in this way, the political and economic interests of former colonial powers and neo-colonial powers shape the current state of global health. So global health is rooted in colonial medicine, where colonial administrations sought to protect their investments and to prevent the spread of infectious diseases. But this was related to the needs of coloniality and to maintain trade and production, rather than to provide healthcare as a basic human right. So in this way, tropical medicine was driven by Western imperialism, and medicine was used as a way to control and civilize people. And this ideology is closely intertwined with racist beliefs. In the early 20th century, tropical medicine became known as international health, but the mentality was still the same. So here we can see a lot of saviorism and the attribute that any intervention is better than what already exists in that country. The term global health came about more recently in the 90s and aims to move away from its colonial roots with the goal of advocating for health for all people, wherever they may be in the world. And in this way, global health is associated more with the concepts of unity and transdisciplinary action. Yet, as Mariam Fofana said, despite its seemingly more inclusive appellation, the intellectual, financial, and political centers of global health remain firmly ensconced in the first world. And a prime example is the headquarters of the World Health Organization, sitting in Geneva, Switzerland. So global health is inherently colonial, and this can be seen in the priorities in funding, parachute research, where Western researchers swoop in to help low-income countries, the choice of paradigm and course literature that's used in education and research, and the visible prejudice in the kind of language used, hiring policies, international policies, as well as conduct and publication practices. So through these financial, educational, and academic imbalances, the former colonial powers are allowed to maintain the status quo. The colonial legacy of global health still perpetuates inequalities in the world today.
Thank you, Simone. Now just to talk a little bit about health equity, we can start off with the gardener's tale. I don't know if most of you have heard about this, but it's a very good illustration of a way to view health equity. So in this gardener's tale, a gardener fills two flower boxes, one with rich soil and the other with poor soil, and grows two different flowers, a pink one and a red one. And the gardener prefers the red one over the pink, and therefore puts seeds for the pink flower in the poor soil and the red flowers in the rich soil. The red flowers flourish and grow a lot, while the pink flowers in the poor soil don't. And this goes on and happens every year as how the gardener plants these flowers. And after 10 years, the gardener says that they're right to prefer the red over the pink. But this gardener's tale within this illustration talks about three levels of racism. The first one is institutionalized racism, where flower boxes with different soils, but they're not addressing the differences. And in real life context, it just shows the differential access to goods, services, and opportunities in society by race. The second one is the personally mediated racism, where the gardener plucks the pink flowers before they can seed or sprout. And this just illustrates prejudice and discrimination. And the last one is internalized racism, where this bee kind of comes in and tries to pollinate the pink flowers, but the pink flowers refuse as they want to be pollinated by the red, as they think it's better and more valuable. And this illustrates how acceptance by members of the stigmatized races of negative messages then accept these messages about their abilities and intrinsic worth. But altogether, this tale just kind of allows us to reflect about who the gardener is and how we can put things right in this garden. So going on forward and talking about equity and health equity, equity is the absence of avoidable, unfair, or remedial differences among groups of people, whether those groups are defined socially, economically, demographically, geographically, or by other means of stratification. When we look at health equity, it means that everyone has a fair and just opportunity to be healthier. When we're talking about health equity and achieving it, we're talking about removing obstacles to health, such as discrimination, poverty and their consequences, including powerlessness and a lack of access to good jobs with fair pay, quality education, and access to healthcare, to name a few. And it's different from equality in that you're not just giving everyone the same thing or treating everyone equally. You're meeting people or populations where they're at and distributing things in a justly way according to their circumstances. So just to look at it more with a relevant example of what is happening currently, we can just look at COVID-19 and how that has affected people and populations differently, whether it be within or between countries. So when we talk about vaccine inequity or equity and COVID-19, vaccines should be allocated equally across all countries, regardless of their developmental or economic status. But this is not what we've seen. Currently, high-income countries who make up around 15% of the world's population have received 45% of the world's vaccine, whereas low-income countries who make up almost half of the world's population have only received 17%. And this is due to grabs by rich countries, protection of patent rights by governments, preventing wider production of vaccines, lack of adequate supply of vaccines to initiatives such as COVAX, as well as vaccine nationalism and vaccine diplomacy. And if you look at this map, this is a COVID vaccine-19 tracker, and you can just see that those in darker purple are high-income countries who have received almost 80% or above, at least with their first doses or second doses, whereas the ones in the lighter shades were low-income countries that haven't received 30%. So moving forward, we can look at this illustration, and this is just something that shows the lack of sharing of intellectual property due to prioritization of profits for big pharma and not people's lives. And this was during the pandemic. So just to quickly describe it, it's that it just starts off by saying that the world has continuously faced shortages of medical tools, often hindered by intellectual property restrictions. But during this pandemic, with how quickly it has spread and the different variants that have developed, the current system is not fit for it. So in 2019, India and South Africa, with support from over 100 nations, asked the World Trade Organization to approve the patent waiver so that multiple nations could manufacture and supply medical tools during this pandemic until global herd immunity was reached. But this was not approved, as wealthy countries refused to waive the IP, making it hard for COVID-19 tools to be more easily available to everyone, everywhere. And this situation just comes to show what people or institutions' priorities are and how corporate profits are being valued over people's lives, even in a crucial time like this, such as COVID-19. Also, just with COVID-19, we can talk about COVAX. And COVAX is an initiative co-led by the Coalition of Preparedness Innovations, CEPI, Gavi, WHO, and UNICEF that aims to accelerate the development and manufacture of COVID-19 vaccines and to guarantee fair and equitable access for every country. And in the beginning, we just saw how this initiative failed as they missed their 2021 target due to various reasons such as supply, being naively ambitious, heavily reliant on buy-in from high-income countries, donations coming in last minute to lower middle income countries with little time left before expiring, leaving many of them going to waste as they were not shared in the beginning, and a lack of transparency and collaborations with stakeholders in lower middle income countries. So what we saw was that countries in the global north were securing millions of vaccines for themselves and honestly just being a little greedy with them. But it's also interesting just to see that with the lack of supply, and yes, they were naive in that they were really dependent on like one manufacturer, but also just like the majority of suppliers are funded by organizations such as the Bill and Melinda Gates Foundation, who get to decide who gets what and when they get it. And this also just comes to show that for future pandemic preparedness, low middle income countries need to boost vaccine production and capacity so that they're not so heavily reliant on charity from high income countries, just to ensure that they're not left behind and can deal with adversities timely. And lastly, just on health equity, there is this term that's now getting more attention, and it's philanthrocapitalism, which is the need for philanthropy to become more like for-profit markets with investors and social returns. Now, this is an interesting topic because a lot of people have talked about the merits and drawbacks of this, but I've honestly mainly seen concerns about this, such as there's a lack of transparency and accountability from organizations on their intentions and how they work, that private philanthropy erodes support for government spending on public services, as many of these organizations and charities get like tax deductions or tax credits that result in them paying minimum to no taxes for many years, which takes away money from that can be used to improve or fund public programs. And last but not least, that organizations or researchers conducting studies in low and middle income countries often do so in an unsustainable way. And this is because when doing such research, they usually fund these interventions or studies for the duration of their research. But once they're done collecting data, the majority of them leave these areas without collaborating or co-creating a program that is actually realistic and feasible in these settings.
Great, thank you, Eileen. And now I would like to put some attention on what would the digitization of global health actually look like. So there are a couple of steps that need to be taken in order to decolonize any part of society. And first of all, the current power structures that are in place that help maintain these inequities that we see everywhere, that needs to be dismantled. And then also we need to indigenize, meaning replacing colonialist structures with local community-based indigenous epistemologies and methodologies. And that can be related not just to research, but also medical practice. It's also good to kind of be aware of the way that humanitarian interventions are currently approached from this white savior Eurocentric view. Also prioritizing and supporting local organizations and communities over large top-down organized ones. And then also trying to move away from capitalism in research. So not just from a money perspective, but also aspects of research would be very helpful. So just to give a couple of examples of what decolonized global health can look like, in Botswana in the early 2000s, they started a program called MASA, where the government implemented this large-scale intervention, basically giving free antiretroviral therapy for people living with HIV, and just no strings attached, healthcare for everyone who needs it living with HIV. And their AIDS-related deaths declined very drastically over the coming years after that. And the government was able to take this kind of approach and prioritize its citizens because they were given access and control to their natural resources when they gained independence. Since their main export is diamonds, they're able to use the capital that they gain from that and invest it back into their community. And another way that we can look at decolonized global health is turning to traditional medicine, indigenous and community knowledge, and trying to acknowledge its value and trying to support these communities in their ongoing research for the efficacy of these medical treatments. And also, we need to move more towards a bottom-up structure for research and interventions rather than top-down, like I said. And also, we need to recognize that indigenous communities already have all of the knowledge that they need, or knowledge about what they need to help their own communities. It's just that it's harder to get those tools. And how, as healthcare workers, can we work towards decolonizing? So it's really important, first of all, to work in medicine in an anti-racist way. We need to acknowledge the biases in medicine. One example of this is this tool called the pulse oximeter, and how the way it works, it actually discriminates against people with darker skin tones because of the way that light has to pass through the skin to be able to detect the amount of oxygen in the blood. And multiple studies have been able to show that these devices don't work as well when compared to a gold standard of doing an actual blood draw. And so the manufacturers of these tools have tried to defend it, saying that, well, it's not about race, it's about skin color. But in fact, it is about race, because when these devices were getting developed, they were calibrated using white skin as the default. So those are the kind of biases that we really need to think about and try and recognize in other places, and how can we fix these. Another thing to think about, especially as students, is who writes the textbooks, who is in charge of what epistemologies are talked about in the literature. And another example of this is Carl Linnaeus from Uppsala, as well as other people who practiced eugenics and other kind of ways of classifying people based on race, because that was a way to justify the slave trade and how to justify discriminating against non-white people. So those are things that we need to keep in mind. There's a really useful tool called Liberation in the exam room, which we would be happy to share after this. And it's basically just a list of things that you can do to try and work towards anti-racism in your medical practice or in your research. So just educating yourself about the history of structural racism, eugenics, genomics, and how those have influenced current research practices. Knowing yourself, trying to become more aware of your own biases, and whether implicit or explicit, knowing about your community's history and what are the social and structural determinants of health, kind of like what we talked about with the Gardener's Tale. Trying to hold your colleagues accountable if necessary, and also just on an individual level, when you are seeing patients or working with research participants, just actively listening, actively taking part in their lives in a meaningful way. And also, how can we be more sustainable in global health? It's good to do some research on which organizations are more ethical than others. Partners in Health and No White Saviors are examples of two good ones, especially organizations that focus more on mutual aid. So basically just giving cash or resources directly to people instead of letting big organizations try and distribute resources on their own, because at the end of the day, the people at the community level know what's best for them. Also, worth mentioning again, just make sure you're learning about what is happening in your own country, learning about who are the vulnerable groups in your community and what do they need. Is there a way that you can help here at home before going abroad to a lower income country? And also just moving beyond good intentions, because good intentions, which we've seen through philanthrocapitalism, not always good intentions there, but sometimes it doesn't always cut it. And also collaborating with Indigenous and local populations if you are going to be in a lower income setting, following their lead, making sure the international community is supporting local communities rather than the other way around. Some other important considerations. It's been argued that true neutrality in research does not really exist because of the fact that we bring all of our own experiences and our biases to the research that we conduct. So it's important that we can identify any blind spots that do come up as a result of our biases that we bring. And it's also important to be mindful of the fact that there is going to be a power imbalance between a doctor and a patient, or between a researcher and a participant. And then how can you be critically reflexive as an ongoing process? How can you continue to examine your own powers, your own privileges as a physician or researcher? And then another good rule of thumb is if you are going to conduct research or medical practice in another country, would you conduct this in your own country, on your own community? So keeping ethics in mind with that. I also wanted to bring this to the presentation. This is a really good visual representation of the ways that there are so many different identities that each individual can have. And the closer that you are to the middle of the circle, the more power that you have, and the farther away from the center, the more marginalized you are. So it's also important to keep in mind too that some of these identities are not always visible right away. So sexuality, mental health, housing, perhaps, formal education. It's good to just kind of keep this in mind and know that we are all individuals bringing our own experiences with us. And then we also are going to share this after. We would really appreciate it if everyone took this quiz. It's from BuzzFeed from a few years ago, but it's still relevant, and it's called How Privileged Are You? And it only takes a couple minutes to fill out, but it gives you a score at the end, and it'll tell you just how much privilege you have. And it's a really good way to kind of be reminded of the different intersections of identity. So one last thing that we wanted to do, if y'all wouldn't mind going to menti.com and using this code, we have a short quiz for you guys to fill out. And it's kind of a shortened version of the BuzzFeed quiz that I just mentioned, where those are examples of some of the questions you would see, and they are a bit sensitive. So you don't have to fill it out right now if you want. I just thought it would be kind of an interesting way to get a sense of how everyone feels about this. And so I'm going to go to the Menti, and we can see this in real time, how people are answering. Hopefully you can still see, yeah, the code is at the top. So, and again, I know that some of these are a little bit sensitive questions, so you're not under any obligation to answer them, but we just thought it would be a useful visual. But okay, got some answers coming in, cool. Okay. Don't know how many people are gonna answer, but cool. So yeah, it looks like most of the answers are kind of skewing towards the right, which means that most of us here have quite a bit of privilege, and that's okay. It's just a matter of acknowledging this and kind of being mindful of these types of things as we move through the world. So I'm gonna go back to the PowerPoint. Oh, how do I get out of that? Okay, there we go. And then just to wrap this up, I just wanted to share this picture. It's from the No White Saviors website. They are an organization based out of Uganda. They do a lot of decolonist work, but it focuses a lot on making sure that unethical adoptions are not taking place, and also making sure that white people aren't just coming from high-income countries and trying to set up nonprofits that are unethically run, which is something that has happened a lot in the past. So, but we really like this one because one of their main slogans is, if you're not uncomfortable, you're not listening. And we know that this presentation we just gave talks a lot about some heavy stuff. And it really is tough to kind of go through history and learn about all of these terrible things that happened that we are still seeing the legacy of today. So it's good to be uncomfortable. It's good to just kind of sit with that discomfort and know that, like, that's how progress happens. You know, we need to just sit with that and, yeah, try and learn from the past. So I think that's pretty much it for our presentation. Thank you so much for listening and for having us.
Thank you very, very much, Eileen, Gillian, and Simone, for the wonderful presentation. I'd like to open the floor for questions and discussions. And I have got some questions actually written to me in the chat, and also pre-made or questions that were sent in before this. So some of them might not.
Does anyone have any questions they'd like to ask us? Could you not hear him?
So I have some pre-made questions, or pre-made in that sense that they were made before the presentation. So you might already have answered them a little bit, but then I've got some new ones. So I'll write the first one in the chat, and maybe you can try to answer it from there. And also, if you have a question that you want to ask just directly, please do so. You can either raise your hand or just speak. So I'll send the first question here that came before this lecture from the Google form. So, can a white doctor from a Western privileged country work in, example, different African countries without being a product of the white savior complex? How can one overcome this issue? And I know that you've already touched upon this in your presentations, but maybe you can elaborate a little bit further. I leave the floor to anyone from the DHG.
Yeah, that's a great question. Yeah, and it is a very important one too. And it is possible, yes, for white doctors from high-income countries to do this work without kind of carrying that colonial legacy with them. But like I said, it has to be from a place of wanting to collaborate with the community in the country that you're working with, as opposed to just coming in and saying, this is what we're going to do, this is how we're going to do it, and no one can say anything else. So, but again, I really encourage people in this position to also just focus on their own communities first. And if you really do want to go to another country that is of a lower income, then really try and investigate why, and try and suss that out, try and sit with that question for a while before you make the jump. So yeah, I don't know if Eileen or Simone want to add.
I'd like to add a little bit to that. I agree with what you've said, Gillian. I just adding on when you're thinking about why it is that you're wanting to do that, really being critical and being reflexive, because why do you think like you would be of value there as opposed to a doctor in that country who can speak the language and who understands the social context? And yeah, so that would just be my comment on the question.
Thank you very much for interesting answers. As you stressed before, like the importance of reflection and to think before you act, and to be a good listener and to ask these questions. Do we have any other questions from the audience? Otherwise, I still have got some that were sent in before and during. Okay.
I have a question.
Yeah, go forward, Alice, please.
I just read an article by Layoba Hirsch. I think you're familiar with her from London School of Tropical Hygiene and Medicine. And she wrote a quote that I reacted upon. And it was that right now we are trying to fix a system with parts that are broken. And I think that it's quite spot on like what is going on with the development, that you try to fix things with parts that are broken, that you have to change the entire system. What parts do you see are broken that needs to be replaced, and how is that possible?
Yeah, that's another really good question. Because yeah, that kind of goes along with the dismantling everything kind of part of that process. But I think one of the best ways to approach this is within academia, because that is where the knowledge is created. That is where these ideas are formed and perpetuated. So I think that could be a really good way to kind of get to the root of this problem, is to kind of change it from the inside out in that way. But I don't know if you want to add anything.
No, yeah, just to add on what Gillian said, I think academia, just research in general, is a very good place to start. Especially just as we were talking about sustainability, or just going into these low middle income countries and thinking you already know what their problem is, or you already know what to fix, but then you should ask yourself, like, have you done a needs assessment, or what systems do they also have in place that actually probably is working, but just in a different way from what you are known to know. And I think also just understanding history is a very big part of it deeply, and not just shying away from maybe someone that you thought, oh, this is a good person, but has done something that was problematic. But knowing the history of a situation or a culture or anything is very key to just understanding it, and how you can move forward, and how you can, I guess, build it back up if you want some progress.
Can I answer that a little bit? Just on your analogy there, I think also when you're thinking about what the broken parts are, I also think you should be aware of what tools you're using and whether those are the correct tools to fix those broken parts or not. Thank you. That's an elaborate answer. Thank you all.
Okay, thank you very much. It's so interesting to sit here and listen to all of these interesting questions, and also to the interesting answer, and it really makes you think. But also, as you stressed before, thinking uncomfortable thoughts coming from a global North institution. And the next question is a little bit about or academia focused or institutionally focused. I'll send it in the chat again, and I'll read it out loud. And maybe you could apply like a local perspective on it, on your work at KI with the, I know that you're studying the public health masters. So big universities include global health more and more, and therefore many leaders in health have studied at the same universities. How should these universities include this question without claiming it? And I think the author of the question might refer to claiming the question of decolonizing, I guess. If the author of the question is here, they can add, maybe. But yeah, sending it over to you, Gillian, Simone, and Eileen.
Yeah, so again, I think that one of the ways that we can address that is looking at what is the balance of different people coming in from different places to study health, because so many of these programs are in the global North, as you said, and yeah, we're kind of just getting the same kind of people in these programs. So one of the ways that you can address that as an institution is creating scholarships for more people from lower income countries to come and study. Also, this is kind of on a bigger scale, but maybe just we need to be able to have more of these institutions in lower income countries to begin with. It doesn't just have to be people going to the global north to learn about global health. Like global health can be taught anywhere. So that is a really concrete way that we can address that. Yeah.
I have a question on that subject. What response have you had from KI, from your organization? How have they been responding to you?
Yeah, so the group, like we said in the beginning, we created a policy document trying to detail all of the ways that we would like KI to change education and research practices. So we presented that to the president as well as some other department heads back in April, and they were maybe not as on board as we would have liked them to be at first, but I think after letting them sit with it for a little bit longer, a couple months later, we presented it again to the Department of Global Public Health, which includes public health sciences, the program that we're in, as well as the global health master's program. So we're trying to kind of implement this policy, starting with this department, and then hopefully we can get it to be university-wide. So we do have some faculty members on board who have expressed interest in getting this policy going. And so it seems to be going really well so far, and we're really hopeful for the future of KI.
That's great to hear.
Yeah, definitely. And do you see a future outside of KI in Sweden? I mean, Sweden, of course, is a very small country, but we have quite a number of different global health educations around, at least in Umeå, Göteborg, and Lund, and Uppsala, I know. Do you know anything about those places?
Yeah, that's actually one of our projects that we're going to be working on this upcoming school year and beyond, is to get collaborations going with other universities in Sweden, because we are the Karolinska chapter of Decolonizing Global Health Sweden. So we would like this to spread to the other Swedish universities that teach global health. And ideally, we could have it be a movement that includes all universities that teach global health. That's kind of the end goal. So that's what we're working on this upcoming year. Yeah.
It's very fascinating to hear. I hope that you can get some new associations going in the other parts of Sweden as well. Just out of my own curiosity, do you have a lot of contact with the other movements, say globally? I know that you, for instance, come from 3 different countries and 3 different home universities here. How's like the international movement looking?
Yeah, I think even when DGHKI was building, the founders, should I call them, they did reach out a lot to those in Duke and for like insight on how to go about it. And even when the policy paper was being formed, they did send the policy paper through to these other chapters to review it and to kind of see like where can there be improvements in this policy paper. And I know a lot of some of those individuals who do work with those other chapters have been included in the conferences that we've had. But I definitely think there needs to be a better collaboration between the groups. Yeah. Yeah.
Nice. Thank you for the answer. It's a fascinating movement. And I saw that on one of the pictures you had in the beginning, you had the sign that says, oh shit, I forgot the name of it, but the movement to take down the statues of Cecil Rhodes, for example. A person who, yeah, I'm a bit bad at telling the backstory there, but that's also an international movement, I know, about decolonizing other forms of academia as well, and not just in the global health departments. I have another question, if you're up for it. one that I think has been answered a little bit during the talk, but I'll send it in the chat once again because it's quite long. Coming from a global north perspective, how can I perform global health research that would not be characterized as a colonized way of science? And then the questioner says, I know that you mentioned this in the talk, but maybe you can elaborate a little bit.
Yeah, we gave a presentation actually that talked a little bit more about this to some of the PhD students here at KI last month. And we focused more on a research perspective and how epistemic violence has pervaded in terms of global health research. So basically, a lot of the stuff that we mentioned earlier too, of kind of ignoring Indigenous people and their ways of knowing, and looking at knowledge as something to discover, something to be extracted and taken back with you to your home country after you conduct research. So that's a big part of the colonialism in global health research, but then also the practices of ethical methodology, as well as critical reflexivity, are ways that we can move away from colonized research.
Yeah, no, I agree with Joel. And just also, if we're talking about just doing research in other places, just making sure like you're thinking about also how you're going to include or collaborate local people in those settings, and just seeing how not only will it like thinking about, oh, how is it going to benefit me so I can publish more papers, but truly thinking about, is this research that I'm doing, is it going to help the setting that I'm in? And how is it honestly going to be sustainable in the setting? Because you can pay for your research because you're getting funded by it, but at the end of the day, in 10 years' time, will that program still be there? I think is a good way as well. So.
Super interesting answers and perspectives. It's really the thing that when you start a process, how do you control it, and how do you make or allocate the resources in order for it to survive, so that it doesn't become an end project. It's very fascinating. It makes you think to the bigger picture, of course, not just about global health, but also with the development aid and how all of these questions are thought about. Alice, you're unmuted as well. Did you have another question?
No, I was actually thinking about wrapping this up, seeing that it was such a nice statement from you, Eileen, there.
Yeah.
If we don't have other questions, I just felt like that was such a nice last line, and just like a takeaway message also to about the research and about what we can do, and to coming back to that point where we really reflect upon what we're doing and why, and is it because of our own interest, or is it because of the interest of someone else as well? So if anyone else has any questions, it's time to ask them. Otherwise, I think it's time to say thanks to the Karolinska chapter of Decolonizing Global Health. Thank you very much for coming tonight. It was really interesting, and I, for one, learned a lot about this perspective. I really like to see the images once again and to take that with me. And hopefully we will see your organization on more locations in the future. You never know. And as a thank you, here is the picture once again. So we asked you what organization you wanted us to send some money to, and this is the organization that you chose. And that's also the organization that we are going to send money, partly from our local cashier, but also nationally from SLS KUF. So we will donate 500 kronor to this association from us in your name to support their work.
Thank you.
Thank you. And now time for a little commercial then. So the next event on Global Health Weeks that is den globala sjukdomsbördan, so the global burden of sickness, why your health is affected of where in the world you are born. So it's a bit of a continuation on this theme, which is health and equity in general. So I hope that you will tune in on that one as well. That is on Monday, and that is organized by Gothenburg and Agnes, who I think is with us tonight as well. So I would like to thank you all for coming, and a special thank you to DHG. Thank you so much for coming. Thank you. And this is our last slide with our contacts. If you want to engage in SLS KUF, or if you want to become a member or have any questions, please feel free.